Good afternoon and welcome to Contemplating an Agentic AI Future. What IT leaders need to know. A health system CIO production sponsored by Quisitive. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You can send in your questions or comments at any time in the Q&A box, and we'll take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35-40 minutes with our main panel discussion featuring Dr. Kerry Bomarito, VP, Enterprise AI and Decision Intelligence with Mercy, Tony Ambrosi, SVP, Chief Digital and Technology Officer for Pharmacy and Consumer Wellness with CVS Health, and Ruby Knight, Healthcare Industry Architect with Quisitive, and then we will have our Q&A. So let's jump right in. Very important topic, and this is going to be a great conversation. So, Kerry, let's start with you. Can you give us an overview of your organization and your role?
Sure. Thank you. I am Vice President of Enterprise AI and Decision Intelligence at Mercy. Mercy is one of the largest Catholic healthcare systems in the U.S. We have over 50 hospitals across Missouri, Arkansas, Oklahoma, and Kansas, and we serve about 3 million active patient lives. I work within our enterprise data and AI office, and my team oversees consumer and provider analytics, geospatial and market insights, financial and clinical modeling, and I have both traditional machine learning and generative AI initiatives. We've implemented over a dozen machine learning models, and we've also deployed 4 generative AI products within our organization, including a real-time clinical handoff tool that's used by our nurses. Our mission really is to integrate intelligence directly into decision-making and care workflows across our organization.
All right, very good, Kerry. Thank you. Tony?
So Tony Ambrosi, I'm the Senior Vice President and Chief Digital and Technology Officer for the CVS pharmacies. And I'm also responsible for Enterprise Digital for CVS. A little bit of a background, I think you, Anthony, and I have been talking before. So I think part of me being invited here is from my years being the CIO of a hospital system in South Florida. We talked about a bunch of things at that time, probably including ML at that time. It was just prior to Gen AI coming online. Obviously, now this is a very big topic for everybody. So thank you for having me.
Oh, absolutely, Tony. Thank you for joining. Ruby?
Yeah, sure. I'm in the company of icons for sure. So Ruby Knight with Quisitive. We are a award-winning consulting firm, so we have global presence, and we specialize particularly in healthcare and helping organizations really achieve good business outcomes with enabling solutions. So we've got we're completely aligned to the Microsoft portfolio, and we have SaaS offerings in our MazeCare solutions. So I'm excited to be here today. Thanks.
All right, excellent. Thank you, Ruby. All right, we're going to jump right in, get into it. Kerry, we're going to start with you. Let's start with the basics. How do you define agentic AI, and how does it differ from the generative AI models that most health systems are experimenting with today?
Specifically at Mercy, right, when we look at how we're using and deploying generative AI, it really is around content generation, right? Writing text, summarizing text, and really being able to respond to maybe even a single prompt. And so an agentic system and how we're thinking about those is really taking that and making it autonomous. And so taking it a step further, not just generating content, but taking action. And so really shifting from these tools that are assisting our coworkers, our providers, and taking it to an execution of tasks. So, you know, an example could be, right, we're actually summarizing content for prior authorization, for example, but then using an agentic system to take the actions necessary to send a prior auth through the process.
Carrie, let me ask you a follow-up. Are these two different tools theoretically where a generative AI would do part of it and a totally separate tool would do the agentic AI part, or are they somehow melded into each other?
Right. Agentic would be more the orchestration of multiple tools. I mean, we hear people talk about agents, for example. You're seeing a lot of things considered all of a sudden branded as agents that were already in existence. And I think it's just some of the terminology and then thinking through the orchestration of those agents and them acting on their own is really where I think we are referring to what is called agentic AI.
All right, very good. Tony, your thoughts?
No, I agree with Carrie. I think we in technology are very good at all these marketing slogans and sometimes rebadging things. Agents are really the intersection, if you think about it, just as Carrie said, at the intersection of AI intelligence usually is Gen AI based with automation. It's really one where indeed you have these agents that act in intelligent fashion. We've had RPA for several years to do the automation, but it was very scripted. It was great, especially when trying to interface with older systems, like mainframe systems. I see Ruby kind of smiling about that. I'm sure a lot of work being done there. Now you kind of put them together in a more autonomous fashion. And then that means that the applications are practically endless because it's the automation can be against anything, including APIs, including everything else. Things that we used to do in a more scripted manner and more difficult to deploy.
Tony, when we talk about generative AI, a lot of that is being baked by the vendors into their products. So sometimes when people say we're doing AI, it may not mean too much more than we're getting it from our vendors. Is agentic AI different in the sense that this orchestration has to be done on the provider side by and we're usually, Tony, going to be talking about health systems, even though you're not at one right now. But does it shift? Does the work shift in terms of this has to now be done by the user, this orchestration?
Well, it depends. What we're doing is, and it's the same with the AI itself or the Gen AI itself, depending on what we want to do, whether there is a vendor or not. I think a lot of folks do, even including in healthcare. I've done before I left the hospital system quite a bit, and some of it is internally developed. And therefore you interface with the models, sometimes maybe even train the models. Certainly the prompt engineering at the integration layer. I'm not talking about the chat paradigm. I'm talking about the system calling another system, and that can be done internally. I'm sure some vendors bake their agents like this, and I'm sure increasingly we'll see that. And where you get from, let's say, Epic, an agent that does a bunch of things, and that's fine. There probably are opportunities for us as technologists in healthcare to do a lot ourselves. That gives us more control. One of the things is that the models are evolving incredibly fast. So switching between models for better intelligence, better reasoning, frankly, that's been a big problem so far with Gen AI, chain of thought capabilities. Those are the ones that help increase the confidence in this technology. So we do switch models. We also need to be very judicious in what models and whether sometimes do we just need the good old-fashioned ML. And I can't believe I'm saying good old-fashioned ML that we were all doing just 5 years ago. And that was the biggest thing on the planet, right? But sometimes it's a combination. That when the teams have the ability to do that, I think the results are more powerful.
That's
Well,
interesting.
I would even add to that, outside of just good old-fashioned ML, sometimes you just need to pull information forward. And so even in some of our generative AI products, we are just parsing in discrete information that was in different screens within our EMR. Right, there is no reason, I think, to use Gen AI machine learning if it's not necessary, right? We want to reduce the risk of the information being misinterpreted or possible hallucinations. And then there's always a cost to it too. So part of this is using AI also where necessary, when necessary.
Real quick, and Ruby, I'm going to get to you in in a second. You talk about so whenever we talk about generative AI, that's when we're talking about the hallucination possibility and the risk. When we talk about machine learning, uh, then we're not talking about that. So we haven't introduced that risk. And where does agentic AI fall on that scale, Kerry?
For the risk of agentic AI, I think since you are basically setting up sort of an autonomous orchestration, right, there's going to be risk, especially if it's used in clinical decision making, and there's not a human in the loop. And so, I think as we're thinking about it is how do we move forward to really show the value of this, but also in the lowest risk um, use case possible. And so thinking about testing that out with some back end processes and things that because you're going to have to prove out the value and get that cultural shift for agentic AI, just because there is going to be risk. I think you also need to look at the whole governance process. I mean, it's a complicated, exciting, but yet very cautious new future with, I think, the aspect of agentic AI.
Very good, Ruby. Let's bring you in here. Lots of stuff there. I'm going to let you jump in wherever you want, whatever's been most interesting to you, and let's hear from you.
Yeah, no, a great dialogue. I do want to circle back to Carrie's comments on risk and economics, but yeah, I'm glad for this question. The science is getting better, right? So when we think of Gen AI, it was very task oriented. It enabled us to do a lot of great things, but I think more importantly, it gave us a broader aperture around what's possible. And I think as we shift from AI being an optional lever for organizations, it's now imperative. And so generative AI, excuse me, very task oriented. Agentic AI, on the other hand, is positioned to make decisions for us. Another step closer to being autonomous, which I think ultimately drives better outcomes across the board. So just as folks were starting to embrace this new thing called Gen AI, here we are advancing the technology. So I think real value emerges from what we're seeing show up today, and being able to complete tasks, have agents speak to each other. And we've got a myriad of use cases to tie into both clinical, operational, and even just the experience side of agentic AI. So.
Ruby, what are your thoughts on this human keeping a human in the loop dynamic? You talk about it as a positive, autonomous things being done without human interaction. That's obviously a positive in terms of scalability. Whenever you put a human in the loop, you're really slowing things down. But especially on the clinical side, most folks are extremely uncomfortable with the concept of removing a human in the loop. Of course, you're going to have all different kinds of use cases where the risk is at different levels. But what are your thoughts on balancing human in the loop, which impedes scalability, with human out of the loop, which may increase risk?
Yeah, I think it's important, and I think you're always going to see a human in the loop. Now, the dimensions of that will probably evolve as you know, with the technology. But from an economics perspective and a risk perspective, I think it makes sense to have someone validating, or some governance or boundaries or clear definitions around, you know, what we'll tolerate as far as agentic AI is concerned, and the associated risk, and what we won't. On the economic side of that is, you know, what is the cost of inaction? So when we look at the cost of inaction, I mean, that's fact. When we look at ROI, you know, it's a maybe. Maybe we'll get some operational efficiencies, but if we treat agentic AI as imperative, and I referenced that earlier, then it becomes, you know, the topic now shifts from where do we need to scale, where do we need integration, and where are our value pools within our organization, and then where do we start? And I suspect some of those we'll get into later. So.
That's a lot of great
Yeah,
stuff there. Go ahead, Tony.
and I think, you know, I totally agree, absolutely, and there will be different use cases where we can accept risk. Clearly, from my 2 cents, from a clinical perspective, I would be extraordinarily cautious. Look, I'm a technologist, but still, we are far from, we should be far from whatever the folks in Silicon Valley are trying to sell that, oh, we can replace doctors. That's crazy. This is just crazy. We need to be very, very careful. Look, it's not different than having a bunch of interns, you know, or you know, medical students. Do you just let them go and do brain surgery day 3? No. And so it's the same. We're getting to that exact the same logic. We balance, you know. If an agent orders too many paper clips or too few for a hospital, nobody will die. But you know, as they get closer to the patients, then it's we should step back and say, wait a minute, we need to think this through very carefully. I'm sure vendors, technology vendors, will try to say, oh, this is safe, will be implemented over there. Why don't you use it? But we need to be very careful.
And Tony, when we talk about thinking through things, is that what we mean by governance? We want the right people thinking through these use cases and making a decision about risk.
Yes, governance is part of it. Obviously, governance in many cases, especially in IT, hasn't, you know, that term hasn't been a good one, doesn't have good reputations, whether you call it governance, which is some sort of gating criteria, which needs to be happening, or what I would call the product definition. Somebody needs to think through and the implications, because this is the other thing. We have agents. Guess what? We're going to have agents controlling agents or interacting with other agents. Now, all of a sudden, you have not a complicated situation, but a complex situation where the outcomes are going to become a little bit more unpredictable. We really need to think through those well.
Yeah, and just real quick, and then I want to get to Kerry. When you talk about, you kind of alluded to governance maybe having some negative connotations sometimes. Do you mean by that sometimes we see governance as a place where initiative dies? Yeah, that's
Sometimes for good reasons, by the way. You know,
right.
and these may be you know, that will be the place to say you want to do what. But other times is maybe in the past, you know, for the last whatever, however many years we've had technology in businesses, maybe, but it has to be some sort of gatekeeping, to be honest with you, because it is the same as I said with the interns. You don't just let it loose and hope for the best. It needs to be very well thought through.
Kerry, there's a lot there. There's the human in the loop concept we talked about, and there's this governance idea about deciding what we're going to allow, what we're going to move forward on. Wherever you want to jump in.
Yeah, I mean, I think from a governance standpoint, and thinking through these, you need to have, right, your compliance team involved, your legal team. We have ethicists involved. There's yes, it can be seen as sort of a place where things may go to die, but there's a reason, like Tony said, there's a reason for it. And it's in these high risk environments in healthcare, there's just things that I think we're learning as we are coming up with use cases and creating products. There's things that we just haven't thought before because this innovation, this technology wasn't available. And so we have them involved now at the start as we're thinking through what the solution is that we're going to build and how it will be delivered. And I'm talking specifically about Gen AI and not Agentic. But just even within that, it just the risks of those things being in a clinical workflow in your legal medical record, just making sure that we're following processes and governance from an agentic standpoint, and letting things loose. I mean, from a technology perspective, I think we need to think about like having simulation environments available. And I think not only will that help around the governance and the testing process, but we can build more trust before we would move forward with an agentic product by at least being able to test it in a as real world as possible environment without it having real consequences at that point.
That's a great idea, point, and I want to follow up on that in a minute. But I want to bring in Ruby, and I want to see, Ruby, do you have any thoughts around this idea of governance? So there's a couple things that have come up with that. It's important, and it could be a place where things get slowed down, but sometimes that's with very good reason. And if it has been slowed down for good reason, I don't think anybody would have a problem with that. You know, what we don't want are things being slowed down without good reason, just sort of bureaucracy type thing. And you mentioned, which I think is a really important idea in this whole dynamic, uh, a little bit referencing competition and the cost. I just wrote down the cost of caution, right? If you're overly cautious with this stuff from a competitive point of view, and even though there's a lot of nonprofits out there, they're still competing with the health system across the street. If you are overly cautious and your competitors are moving forward much more efficiently, you're going to fall behind, and you're not going to be the place where patients want to go. You're not going to be the place where physicians want to practice. So there's an element of that. So what are your thoughts around those issues?
Yeah, I love this topic, and probably for some very simple reasons. But I think there's a mindset here. We always have to keep in mind that the role of governance is not about oversight, nor can it be outsourced. So when we're looking to, architect our path to entry around AI, there are some things that we really need to plan around, well in advance. What will we allow and won't we allow as we embark on this journey? And then what are the impacts to people, process, and technology? And I think sometimes when we're facing significant change, and this is disruptive, no doubt about it. We forget the OCM component. We forget to look at being strategic in how we approach things, because you'll either pay the tax of being too cautious on the front end, or being overzealous and not getting it right on the back end. So planning is always critical, and I think that's a step that sometimes we miss. One of the things that differentiates Quisitive with other firms is, when we interact with customers, we don't standard intake on, hey, we want to do AI. We look at what's your existing security posture. We look at in wave one, what is the foundational or the operational backbone that needs to be in place to do these things, and governance is sitting in that first wave. And then the second wave is where we really start to tap into trends. And then the third phase is where we actually see our future state come to fruition. So when we sit down with our clients, we walk them through that, and governance is a huge part of that. And I think Carrie said it best, but you do need, I would say, cognitive diversity on how you build policies that are changing along with your processes.
All right,
Yeah,
excellent. Go ahead, Tony.
sorry, I would add to that. So this is obviously a competitive conversation. applied correctly in the areas that are ripe for that, it could be also a cost reduction for patients conversation. And also hopefully a increased access for patients. If the doctors don't have to spend hours and hours and hours doing paperwork, they could conceivably recharge that they need to, and they could conceivably see more patients. So from that perspective, that would be good for patients. So I think that's something to keep in mind. It's not just the competition between hospitals, it's what positives could be. And then the same, I think you and I talked 3 years ago when we were talking about digital, the same things. How can we make it better for patients? Getting access, getting being seen by doctors who don't have to waste time on paperwork. But as important as that may be.
Yeah, no, very good. Absolutely. Kerry, let's talk a little bit about use cases. What are your thoughts there? I mean, there are going to be things I assume that this lends itself to, and there are going to be things that maybe it doesn't. What are maybe some of your top use cases that you've been looking at?
Yeah, so Tony mentioned access. I think specifically, if you think about the time that has to elapse after a physician may place an order for a test or look to perform a procedure on a patient, right? We're dealing with a very complicated process in getting that approved by the insurance company. And so we're really looking at right now just using AI in general to improve our process for prior authorization, to reduce that sort of burden on waiting to have an MRI or those sorts of things while we're waiting for that approval, and getting the patient scheduled immediately, but then also reducing the possibility of having it denied, which is not only right financially an issue for the healthcare system, but it just creates such a complexity and burden on the patient too. And so I think in that process, whether it's the front end revenue cycle right during the prior authorization, or then even back end working through denials, all of the tasks that go along with that, I think there's a lot of opportunity within that process. I also think patient engagement, right? So I'm kind of looking at things that are lower risk and aren't really around like clinical decision support, but maybe like setting Agentic around patient follow-up, right? Like messaging patients, scheduling follow-up appointments, reminders, that sort of thing.
Okay. Tony, use cases?
I think that's Kerry mentioned on the patient side, I think, and others have talked about the concept of a personal health AI assistant. And that would be great, because something like that would be able to bring together a lot of transactions, I should say, or interactions or encounters or whatever it is in that journey. And I think that would be very useful. On the front end revenue cycle, one can imagine, I should say, the hospital or the pharmacy agent going back and forth with the payer agent and exchanging information just as two humans do. So normally there's a human interaction, and then questions are asked, answers are being provided, and that kind of solves things. Now we can have hopefully agents do that, and they can do it very fast.
And
that would be exciting for everybody. Sorry,
and
go
those
ahead.
questions change a lot, right? So the payers don't make it easy. And so having, I think, the Agentic or automation in that process, being a part of it, it'll just really reduce the burden on the healthcare system and the coworkers who do those workflows, just because it is an ever evolving issue with prior authorization and requirements, medical necessity checks, all of that.
Ruby?
Yeah, with our SaaS solutions, today we already support, things like referrals and patient management, onboarding, things like that. So I think depending on, the environment that we're in, what a high value use case looks like, it's going to be different from organization to organization. I think the key here, and Carrie touched on this, and I think Tony did earlier, is what's high in feasibility and low in risk, that we can categorize under optimizing operations, right? And then you have the population of existing use cases for those who've already embarked on the journey, and with agents being able to talk to agents, FHIR APIs that we can get into, leveraging existing frameworks that are already in our infrastructure, we can actually streamline the augmentation of use cases that are existing, and create more advanced use cases under low risk activity. So I think those opportunities are there. If you've not started the journey, obviously looking at which use cases you have on the operational side are easy, low hanging fruit. So and all of this again would tie back to governance, or what your interaction policies will be. And that's what I was saying about policies need to change with processes.
Very good. Tony, this idea of agents talking to agents, especially I guess around revenue cycle, where the payers are going to have agents and you've got agents. Does that need to be thought about differently or architected differently than if you were planning on an agent interacting with a human? Does that present, you talk about complexity. Is that a different flavor of this, or do we have to expect, or do they operate basically the same?
Under the cover, they're the same.
Okay.
So, and frankly, the intelligence and the automation, whether you expose that at some sort of a human interface, or is just system to system, or an agent scraping some web page or whatever, some mainframe system that is 50 years old or whatever it is, or interacting with APIs, I think the behind the scenes, the logic is the same. The implementation is the same. Now, I didn't mean when I was talking agents to agents, I think that's a perfectly good case. But at some point, I want to, reinforce what Carrie has been saying and Ruby was saying. That some human needs to be in the loop.
Mm-hmm.
Now the question is, when do you bring the human in the loop? You may have to have, this is the interesting thing, it's not just agents talking to agents, but it's agents overseeing other agents, and then saying, oh, this is something anomalous here. Hey, human, why don't you look into this? What's happening, right? You need to control these. You have a supervisor of interns. Back to my picture of bringing new interns. Somebody needs to, not just before you launch them, but constantly near real time.
Carrie, it's almost like cybersecurity, where they're having AI monitor lots of things, logs, and all kinds of things, and only the things that are picked out based on certain criteria as reaching a certain level of risk are brought to a human's attention. So it sounds like something similar. Your thoughts there, Carrie?
Yeah, I mean, we it, we think about AI monitoring AI. It's definitely something I think that we need some caution around it first, right? So even internally with our ML ops processes and trying to monitor our LLMs, think about like the Swiss cheese model, right? There has to be multiple things I think available for that. So we're not just using an LLM to monitor an LLM. We're also using math, like things like cosine similarity. And so I think having multiple guardrails in place when we do get to an agentic system, where it's not just like an agent monitoring the other agents, that we need to think about, and I don't know the answer to this yet, what other guardrails can we put in place so it's not just AI monitoring AI as it is. I mean, eventually, the accuracy, we can maybe move into that, but I think we're not there yet, and so we just need to, I think that through and be cognizant of it.
Ruby, any thoughts there?
Yeah, I feel like it's now been it's more important than ever to ensure that we have a robust framework in place. And I've said this several times, but one of the things that are impacting how we've done things in the past is the regulatory landscape is changing. So even though we may put some things in place, they may be incongruent with what our new administration is suggesting we proceed. So there's that. But I think at the end of the day, we have to be extremely diligent in limiting access and making sure that we have the proper segmentation in place that, if bad actors try to undermine, our efforts to reduce clinician burnout or address labor shortages, and even, drive operational excellence, that with Agentic AI, that we're able to do that without disruption and to our business, and with continuity intact. So
Very good. I want to go back, Kerry, to this simulation environment that you mentioned is quite interesting to me. I actually did an interview a day or two ago with a chief innovation officer, and that was more on the clinical side, where he talked about what's really worked for him is to have this sort of specially set up ward, where it's almost like a lab, but it's actually got real clinicians and real patients, but it's separate, and it's sort of where they can play over there and not impact the usual workforce, because that proves to be unscalable and difficult to keep interrupting sort of business as usual. It's nice to have a little sandbox to go play in. It sounds like you're talking about something similar where you can play around in there and experiment and try things. Tell me more about that. And again, other people may want to replicate something
Yeah.
like this.
Yeah, I mean, so interesting enough, we actually do have an innovation unit at Mercy. And so we have the same, we have nurses and physicians that want to try new technology and really test it out, and be sort of the leaders in that space, look at whether or not we're going to adopt it, and then help like really communicate that more broadly as we scale it out across our organization. Yeah, from a agentic system, I think testing what's built out. I've been looking at, I think, as we think about agents and what we want to use to build them within our own cloud environment, right? We want to look at not, we're going to have, there's so many vendors out there that say they have agent capabilities and even are saying now that they have agentic capabilities, that you could end up creating these silos of agents or agentic systems that only work within this one software system. Right across healthcare, we have so many different environments, including our EHR and other systems that we may want to talk to, that I've been looking at how to orchestrate, build agents and orchestrate them, right through API management and across multiple software systems, but also have, right, like this simulation environment built out. And so, we, throughout our, I think our cloud, we have an intelligent data platform at Mercy, which is our analytics and AI environment that we have integrated in with our different software solutions, including our EHR. And so within that, there are certain agent vendors in the market right now that do have simulation environments that they can help you build. And so we're just trying to vet that out and understand what kind of capabilities that would bring in if we use those, and how they would integrate with our different systems at Mercy. And just because I think that's where we can build trust and really be able to test things out before scaling them across the organization.
Tony or Ruby, any thoughts on this kind of sandbox type thing for this stuff?
Sure, I'll jump in. Yeah, to Carrie's point, I think there's tremendous value in cross training, and in that cross group collaboration. I would also say one of the things that we talked about Gen AI earlier and agentic AI, but even when we're in those sandbox environments, testing things out safely, we still have the option to ask Gen AI to write out those use cases for us. So as we're coming across new discoveries and value pools, that's one way we can kind of summarize and continue to catalog the use cases that make sense for our organizations versus the ones that are probably less of a priority.
All right, very good, Tony. Let's talk a little bit more about interoperability because it sounds like this idea of orchestration and this agentic AI we're talking about. Is this often going to depend on systems interacting with each other that are really fairly siloed, and we need to leverage things like Fire and HL7 and these things, and nobody's happy really with where interoperability is in healthcare. It's kind of this big frustrating thing. But tell me, to what degree does success with agentic AI depend on getting really good with this stuff?
I think it's probably the agents will help. You're right. Interoperability, a big problem. Whether a EMR vendor has a interface, Fire HL or LHL7 or what have you, has been a problem. For integrating systems, for building digital on top of systems has been a problem. And that will continue to be a problem. I think the agents, because they're now a lot more intelligent and having better RPA capabilities, I think it will going to help. It's going to help a lot. We've done RPA in front of older EMRs that did not have any type of APIs. It was painful, and now it's, to say the least. But I think that is getting a lot simpler. Now, I would also say is, other than those old systems that you can't change very much about, I don't know if the newer systems, is there any logic for them not to have in this day and age of code generation and API generation, what have you? Is any reason or good reason, good explanation for them not to have those APIs? 20 years ago, maybe 10 years ago, writing an API, exposing an API might have been a big deal, at least in healthcare. These days, I'm not sure how that could continue to be.
Kerry, any thoughts around interoperability?
Well, I think with agentic AI, with generative AI, with all of this, right, the foundation is your data. And so, at Mercy with our intelligent data platform, that's where, right, we have data governance. We've set up really the core infrastructure and source of data, whether it's from our EMR, whether it's from our financial systems, our supply systems. I think the interoperability and the build of agents in other software systems that may then be in a different cloud environment, because that's how they're hosted, right? That's where I think you just don't want to create these silos. And so, because of the importance also of the data needed to have these agents act accurately and autonomously, that's where I think all of this needs to come together, because otherwise you're going to be putting data here and data there, and how do you govern all of that too?
Yeah.
And how do you monitor it?
Right. Very good. Very good. Ruby, interoperability?
Yeah, this is I think this is probably one of the more critical areas and motivators, to take initiatives forward. At Quisitive, we think of our approach into AI in terms of crawl, walk, run, fly. And so one of the things we want to do, we don't want to rebuild. We don't want to rip and replace. We want to integrate with existing systems. And what Carrie said, was pretty astute in that you have to begin with a data strategy. And so I would say that's probably inferior to an operational backbone. I think it's a component that's essential to ensuring that you have a successful experience. We talk about unlocking data to get to insights. You'll need those as you begin to map out the scope for, where you want your agents to operate. We think of connected experiences. You'll need to unlock data in order to piece together some of these monolithic systems that we rely on a day-to-day. So I think the opportunity is tremendous. We at Quisitive have a number of programs that kind of help with scope around how should we interoperate, where should we integrate, which APIs do we need, and do all that planning on the front end so that you can keep going without a bunch of stop starts. So the last piece is this is absolutely a great opportunity to start thinking about what capabilities you have in your workforce. Do we need to cross train? Do we need clinicians to have some 100 200 level aptitude around AI capabilities, and how does that look? So I think I think the road ahead is mapped out pretty clearly, and we've got a lot of work that sits in front of us.
Ruby, we got an audience question. It's from a physician at a health system. She's just looking for a little, I guess, a little more clarity around the definition of an agent. And I'm going to put you on the spot, Ruby. Can you give us something? Help out a clinician who's trying to get her arms around this stuff?
Yeah, sure. I'll probably explain it like I did to one of the teenagers that asked me at the school a few weeks ago. What is this agent and what is AI? Basically, it is automation enabled by technology to perform a very specific set of tasks or task. So when we look at agentic AI, again, it's very goal oriented. When we look at Gen AI, it's providing summaries and taking tasks to order to make things a little bit easier for us. But all agents are a set of instructions that say do this and do that, if then, and are relying on learning and the governance that we put in place so that they can operate. I hope that answers the question.
All right, very good. Let's go to my favorite part. Oh, well, this is another good one. How do you suggest physicians should be trained in AI? That's again from the same physician. It's a great question. I don't know. Tap your IT department, or I don't know. There's lots of courses. There's courses on LinkedIn. There's all kind of stuff. Any suggestions there for how a physician can maybe get some education or training on AI? Tony, any thoughts there? You know of anything?
Um, sure. So back to your previous question, and our physician friend could these agents are out in the wild for consumer tasks. I believe Google has some, OpenAI has some, and they are agents that basically say, book a trip for me to Alaska, whatever it is, and the agent goes and figures out where, how, and depending on what the instructions are, we'll book trips, we'll book plane, boats, whatever it is, and charge your credit card. And now that's where you have to trust it to do the right thing before it charges the credit card. But they're
You want a
available. So
human in the loop there, Tony. We want to keep the human.
yes, just before that, you say before that last button is pressed. But those exist there. So I think that would be a good thing for anybody to go and look at those. Now outside the US, there is a particular agent that is even more powerful, can do anything, apparently, if we were to believe that. But that would be a good indication. In terms of training, I wouldn't ask anybody, frankly, to go and study how the Transformers are really the technology that enabled Gen AI.
Mm-hmm.
That was something that Google put out in 2017, and then interesting things had started to happen. And the GPT, the T in GPT is actually the Transformers. I wouldn't ask anybody to do that. Even I have difficulties reading those technical aspects. And what I would suggest is everybody to stay aware of what these things can do and the risks and limitations. Yes, we talked about AI hallucinations, which basically we need to understand that hallucinations are not bugs. is not that the model misperforms. It's just the fact that there is no context or reasoning yet in that model to say, yeah, don't eat rocks and don't put glue on your pizza. But that's what I would suggest everybody to stay abreast of what these things can do. They do and can do. That would be something that anybody, even in IT, should do, and say, oh, I have a problem over there, and there's a new solution over here that maybe solves that problem. Let me think about that. And that would be the approach I would suggest for anybody versus oh, what can we do with AI? No, start with the problem, desired outcome, and then go back and figure out whether it's AI, Gen AI, agents, or simply, a linear regression into, a line of Java or PHP code.
And I think that's a great suggestion. You play with it yourself, you learn about what it can do, and it gives you ideas. So I think that's a great suggestion. Ruby, let me give you an opportunity to ask one or both of your wonderful and brilliant co-panelists a question.
Yeah, no, that's great. I actually put a little thought into, where I was going with this, but I'm very curious, Tony. CVS is pretty huge. So, how did you guys consider the use of agents, or are considering the use of agents for patient engagement? Specifically like around coordinating, with providers or things like that. What does that look like for you guys?
And so you're right, CVS is large, and I cannot speak for things outside pharmacy. I mean, there's plenty to deal in pharmacy, but I think that in principle is, yes, we have AI, yes, we have agents that are in that category of, can we improve the operations? Can we support pharmacists with simplifying data collection, just like Carrie has been talking about earlier in this call? Can we enable them? Can we help them? Can we simplify things from them? That's where fundamentally, and again, the human is always in the loop. Yes, I'm not talking about buying paper clips. That shouldn't be a problem, but that's where the focus is. In terms of patients or consumers or customers or engagements, how do we, for example, introduce conversation AI so it's a lot easier to interface than, let's say, with an IVR, with traditional IVR? That's where that's the type of focus that we're having with the human in the loop where it matters.
Excellent. Thank you.
All right, very good. What we're going to do here is we're just about out of time. I'm going to give everyone, we'll call it a lightning round of final thoughts, your best piece of advice for someone in your position at another health system or another organization that is, trying to move forward in a thoughtful way with these things. So, Carrie, we'll start with you.
So, think since we're starting sort of in our lower risk areas, one of the things that we're focusing on is getting our own coworkers familiar with agents, Agentic, thinking about how they can use it themselves to improve their own work processes. Mm-hmm. So even within, right, like the technology stack, building within our cloud environments, the data pipelines, all of that, thinking about how to use agents and Agentic AI to eliminate some of the repetitive processes or things that we can do to sort of help us work on work. And throughout our own group, like our own data scientists, engineers, all of that, getting them that, then we want to roll out a community of practice. So I think once our experts are used to the different tools that we have available to us now, the different agent building capabilities, even getting them used to low code, no code, even though that's not what we normally use, but that within that community of practice, we can bring others throughout our organization, similar to the citizen development that we've done with RPA, for example, is get our other coworkers thinking about, right, how can I use this to augment the work I already do? Right, we're not wanting to replace our coworkers, but get them practicing to top of license. There's so much burnout in healthcare. There's just so many menial tasks that I think focusing on helping your coworkers work more efficiently, think about like how they can use this themselves, and then sort of like kind of expanding out from there, training others to think about the same.
Perfect. Wonderful. Tony?
What I would say is this is this intersection of technologies that I think they're making a difference in kind versus just in degree, a matter of degree. I think it's extraordinarily powerful and could lead to very good things. And who knows what we're gonna be able to do or think of doing in, let's say, a year or two. And there's that short of an interval. I want to go back to we need to think through how we're using it. All these agents, today we may have 2 or 20, and maybe in 2 years we may have 2,000. So now you have all these things that are semi-autonomous or fully autonomous. We need to make sure that we are in control of them and not the other way around. And then, frankly, as soon as things get close to patients, patient safety, patient health, patient well-being, we need to be very, very, very careful and with a human in the loop. Even if that maybe would slow down a little bit the advancement, even that, the human needs to be in the loop.
Perfect, Tony. Thank you. Ruby, we'll give you the last word.
Yeah, thanks so much. So, number one, AI isn't going anywhere. And I think the implications for agentic AI in health and life science and even outside of this industry are pretty powerful. Organizations don't have to go it alone. So I would say start small, leverage your quick start programs. We have several that help clients get off the ground and running and build that playbook and that vision so that they can take things to a broader level. But I think the big key here is start small, target, closed loop workflows, right? Or things on the use cases on the operational side until you pick up the momentum that you need to take things forward. And I think the question posed earlier about training and enablement, I think that in parallel with, planning efforts is a huge accomplishment. So, but that's it. That's it in a nutshell. Thank you.
Awesome. Perfect. Thank you. Well, that's about all we had time for today. Regarding continuing education, you could use the final slide in this deck. You'll receive an email when our on-demand recording is ready for viewing. If you want to work with us, you can reach out to Nancy Wilcox from our team and go to our website to register for upcoming panels. With that, I want to thank our wonderful, tremendous panel, Dr. Kerry Bomarito, Tony Ambrosi, and Ruby Knight, Inquisitive, for sponsoring and making it possible, and you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you.